If you are over 60 and you take a small pill every single day to manage your blood sugar, and your doctor keeps renewing that prescription year after year without a single conversation about your kidney function, I need you to pay very close attention to what I am about to share with you. Because there is a class of diabetes medication that tens of millions of Americans are currently taking. It is inexpensive. It is familiar. Doctors have been writing prescriptions for it for decades. And for a significant number of seniors, the very drug that is supposed to be protecting your health may be quietly and systematically damaging the organs responsible for filtering everything out of your blood. I am Dr. Steven, and this channel exists to bring you the latest evidence-based research on senior health, translated into clear, practical language designed specifically for adults over 60. If you have not subscribed yet, please do that right now because what I am covering today could completely change the conversation at your next doctor's appointment. Let us get into it. The drug most seniors have never questioned. The medication class I am talking about is called sulfonylureas. You probably know them by their brand names, glipizide, glyburide, and glimepiride. These drugs have been prescribed for type 2 diabetes since the 1950s. Your doctor may have placed you on one of them years ago when your blood sugar first started climbing, and the prescription has been renewed automatically ever since. Here's how they work. Sulfonylureas force your pancreas to produce more insulin regardless of what your blood sugar is actually doing at any given moment. It is not a responsive system. It does not wait to see whether your glucose is rising. It simply pushes your pancreas to keep pumping out insulin around the clock. For a 45-year-old with otherwise healthy kidneys and a functioning liver, that mechanism carries manageable risks. For a 68-year-old whose kidney function has already declined, whose liver processes medications more slowly, and whose body no longer bounces back from metabolic stress the way it once did, the risk calculation is entirely different. And the research has been telling us this for years. Comment below right now. Are you currently taking glipizide, glyburide, or glimepiride for your blood sugar? Just yes or no. I want to understand how many people watching this channel are affected by what I am about to explain. What is happening to your kidneys right now? Here is the piece of this story that most patients are never told. After the age of 60, kidney function naturally begins to decline. By age 70, the average person has lost somewhere between 30 and 50% of their peak kidney filtering capacity. This is a normal part of aging, and under ordinary circumstances, the kidneys you have left are sufficient to manage daily life. But when you add a medication that your kidneys must work overtime to process and clear from your system, that already reduced capacity gets pushed toward its limit. Sulfonylureas are metabolized primarily by the liver and then cleared through the kidneys. In an aging body, the liver metabolizes them more slowly, which means they stay in your system longer and at higher concentrations. The kidneys then have to work harder to clear those elevated levels. Over months and years, that sustained pressure contributes to something doctors call contrast-induced nephropathy in some contexts, but more broadly to progressive chronic kidney disease. A landmark analysis published in the Clinical Journal of the American Society of Nephrology followed thousands of older adults with type 2 diabetes over a multi-year period and found that patients on sulfonylureas showed significantly faster rates of kidney function decline compared to those on newer medication classes, particularly among patients over 65 who already had mildly reduced kidney function at baseline. The problem compounds itself in a way that is genuinely alarming. As kidney function declines, the body clears sulfonylureas even more slowly. That means the drug accumulates further. And as it accumulates, the pancreas is forced to produce more insulin than the body needs, which leads directly to the second major danger that most seniors on these medications have never been warned about. The silent crisis, hypoglycemia in seniors over 60. Hypoglycemia means dangerously low blood sugar, and in adults over 60, it is not just uncomfortable. It is one of the leading causes of emergency room visits and hospitalizations in the diabetic senior population. Here is what makes sulfonylureas uniquely dangerous in this regard. Because they force continuous insulin production regardless of whether your blood sugar actually needs it, they cause more hypoglycemic episodes than almost any other class of diabetes medication. A comprehensive meta-analysis published in the journal Diabetes Care found that patients on sulfonylureas had a 2 to 4 times higher risk of severe hypoglycemia compared to patients on newer alternatives. In a 35-year-old, a drop in blood sugar produces shakiness, hunger, and sweating. You eat something, you recover, and you move on. In a 72-year-old, a hypoglycemic episode looks very different. It can cause sudden confusion, loss of coordination, and falls. And if it occurs at night, which is common because sulfonylurias do not pause their activity while you sleep, the person may not even wake up in time to respond. Research published in the British Medical Journal found that seniors who experienced one or more severe hypoglycemic episodes had a significantly elevated risk of subsequent dementia diagnosis. The brain, deprived repeatedly of the glucose it depends on, sustains cumulative damage that over time manifests as cognitive decline that looks indistinguishable from early Alzheimer's disease. Let me tell you about Raymond. He was 74 years old when his daughter brought him in following his second fall in 3 months. He was on glipizide, had been for 6 years, and his blood sugar readings at his quarterly appointments always looked acceptable. What nobody had examined was what was happening to his blood sugar at 2 o'clock in the morning. A continuous glucose monitoring trial revealed he was regularly dropping into hypoglycemic territory overnight, every single time triggering a stress response that left him disoriented and unsteady when he got up for the bathroom. His kidney function tests, which had not been checked in over a year, showed his filtration rate had declined meaningfully since his last measurement. The picture became very clear very quickly. What the research now supports is better alternatives. The medical landscape for type 2 diabetes management has changed dramatically in the past decade. 2 classes of newer medications have accumulated substantial evidence demonstrating not only better blood sugar control, but active protection of the kidneys rather than contributing to their decline. The first class is called SGLT2 inhibitors. Medications like empagliflozin, sold as Jardiance, and dapagliflozin, sold as Farxiga. These drugs work through an entirely different mechanism. Rather than forcing your pancreas to overproduce insulin, they work on the kidneys directly, causing them to excrete excess glucose through the urine. The blood sugar comes down, but only when it is elevated. They do not cause the dangerous overnight lows that sulfonylurias produce. More significantly, a series of major cardiovascular and renal outcome trials have shown that SGLT2 inhibitors actively slow the progression of kidney disease in diabetic patients. The Credence trial, published in the New England Journal of Medicine, showed a 30% reduction in the risk of kidney failure in patients with diabetic kidney disease who took an SGLT2 inhibitor compared to placebo. That is not a marginal difference. That is one of the most significant renal protective findings in diabetes medicine in the last 20 years. The second class worth discussing is GLP-1 receptor agonists. Medications like semaglutide and liraglutide. These medications work by mimicking a hormone your gut naturally releases after eating, which stimulates insulin production only when blood sugar is actually elevated. Because the response is glucose-dependent, hypoglycemic episodes are dramatically less common. Multiple outcome trials have also shown meaningful reductions in cardiovascular risk and, importantly for seniors, some evidence of renal protection as well. Before I continue, I must make something absolutely clear because this could protect your life. Never stop a diabetes medication on your own without direct medical supervision. Stopping sulfonylurias abruptly can cause your blood sugar to rise dangerously. Any transition must be supervised by your physician and managed carefully over time. What I am giving you today is information and specific questions to bring to your next appointment. It is not permission to make unilateral changes to your medications. The questions you must ask at your next appointment. Here is exactly what you should do with everything I have shared with you today. First, find out whether you are taking a sulfonylurea specifically for blood sugar management. The names to look for on your prescription label are glipizide, glyburide, glimepiride, and their brand names glucotrol, diabeta, and Amaryl. Second, ask your doctor when your kidney function was last formally tested. The test you want is called a GFR, which stands for glomerular filtration rate, along with a urine albumin to creatinine ratio. These two together give your physician a clear picture of how well your kidneys are currently functioning. If these have not been checked in the past 6 to 12 months and you are on a sulfonylurea, that is a gap in your care that needs to be addressed immediately. Third, ask these 3 specific questions at your next appointment. Ask, was my current diabetes medication chosen based on my current kidney function, or is it simply a prescription that has been renewed without reassessment? Ask, given my age and the length of time I have been on this medication, am I a candidate for transitioning to an SGLT2 inhibitor or a GLP-1 medication that has documented kidney protective properties? And ask, have I had a continuous glucose evaluation or at minimum a fasting and bedtime glucose check to determine whether I am experiencing undetected overnight hypoglycemia? Fourth, request a comprehensive metabolic panel and HbA1c at your next blood draw if it has been more than 3 months since your last one. You want to see not just your blood sugar average, but your creatinine, your BUN, and your GFR together because the blood sugar number alone is not telling the whole story of what is happening in your body. Fifth, begin tracking your own symptoms in a simple daily log. Note your morning fasting blood sugar if you have a home glucometer, your energy level throughout the day, any episodes of dizziness, unusual sweating, or confusion, and the quality of your overnight sleep. 4 weeks of your own consistent data gives your physician something concrete to work with and makes the conversation far more productive. An important clarification before we close. There are absolutely patients for whom sulfonylureas remain appropriate. If you are managing other conditions that make newer medication classes unsuitable, if cost is a significant barrier and sulfonylureas are what your insurance covers, or if your kidney function is being actively monitored and your physician has made an informed decision about the risk-benefit balance for your specific situation, that is a different conversation. Medicine is never one size fits all. The concern I have outlined today applies specifically to seniors who have been on these medications for years without a reassessment of their kidney function, without a review of whether better tolerated and kidney protective alternatives might be appropriate, and without a conversation about the real and documented risks of overnight hypoglycemia. Dorothy was 71 years old when her internist finally reviewed her full medication history alongside her most recent kidney function panels. She had been on glipizide for 8 years. Her GFR had dropped significantly in that time in a pattern consistent with medication-related kidney stress rather than normal aging alone. Over 12 carefully supervised weeks, her physician transitioned her to a newer medication class. Within 4 months, her kidney function markers had stabilized. Her overnight glucose readings were consistently in a safe range for the first time in years. And she told me she had not realized how often she had been waking up disoriented until it stopped happening entirely. You deserve a treatment plan built on current evidence, not a prescription written a decade ago that has simply been renewed on autopilot because nobody paused to ask whether it still makes sense for the person you are today. Comment reviewing mine if you are planning to bring this to your doctor at your next appointment. Comment your current blood sugar medication below. I read every single response, and your questions frequently become future videos because they tell me what this community genuinely needs answered. If someone you care about is managing diabetes and has never had this conversation with their physician, please share this with them today. One informed conversation can genuinely change outcomes. I am Dr. Steven. Subscribe if you have not already, because next week we are covering the one breakfast food that over 60% of seniors believe is a healthy choice for blood sugar management, but that recent research shows consistently raises fasting glucose in people over 60. It is in most of your refrigerators right now. You will want to know before your next meal. Take good care of yourselves.